So if you don't know me, I'm Taylor. I'm one of the PGY4 EMIMs. I'm doing an EMCCM today. Just thank you to the whole EMCCM team, as well as the providers in this case, and Calvin and Natasha for getting me follow up through the NYU system. So as you saw on the first slide, we're talking about a 55-year-old with seizure-like activity. So her ED course actually starts with a witnessed episode. She was seen on rounds while shift change was taking place. She was in the hallway, and the team observed a couple seconds of upper arm contraction, a fixed gaze staring forward, but at that time, positive blink to threat, and it lasted less than a minute, and she returned immediately to baseline. So they observed this before the patient had really been fully evaluated, but at least at this point, we have her initial assessment, which is her ABCs are intact. And immediately after the episode, she was alert and oriented and was back to her baseline. She had already been triaged. So these are her triage vital signs before she had been brought to the hallway, as well as her finger stick. And I know I didn't give you a lot of information there, but I do want to see if some of the juniors can give me some preliminary problems based on what we have so far. Anyone? Nobody wants to diagnose what she has based off of that. Ooh, Calvin says pseudoseizure, Alex says tachycardia. Great. Any other ones? The only other big one is hyperglycemia. So she does have a finger stick above 300. For right now, we're documenting this as a, thank you, John, for hyperglycemia, as a transient loss of consciousness. The team at that time did think it was a pseudoseizure. That was their main concern. But seizure and syncope are also kind of contained as the other differentials. So with that in mind, juniors, again, what would you want to do for this patient right now? You're stopping rounds to assess her, and then what do you want to do immediately? In-person juniors? Wait, I did those. So what next? Okay, we can get IV access for sure. She's hyperglycemic, okay. I have EKG and monitor from Nata and Alec. Anything else you guys want? Okay. Yeah, so reassess her mental status. So the things that the team want and that I would have wanted was they moved her into a room and asked the nurses to get her on a cardiac monitor, to get IV access, to get basic labs, and to get an EKG. And the Micho also wants a history and physical exam. I appreciate that. That leads me into my HPI. This is all the HPI that we have. It's actually from the triage note and then a little bit of what they spoke to with the husband. He was luckily at bedside and said, this is exactly why I brought her in. She's been having episodes like this at home. He thought they were seizure-like activity, which is why the triage complaint says that. But exactly what the providers observed is the reason that she's in the hospital. No history of any seizures. And the rest of her past medical history, just hypertension and diabetes, pretty regular run-of-the-mill medications, and no known drug allergies. So while your initial interventions are being put into place, she has a second episode, a slightly longer duration. There was concern at that point that she might be having a seizure, so midazolam was ordered. And while the nurse was going to get it, she went into cardiac arrest. So CPR was started. The patient was moved from the room she was initially in into the resuscitation bay. And this was what I suppose the rhythm was at the time, though we don't have, she wasn't actually on a monitor until her first pulse check. But this is what we think the rhythm was. And just for completeness, junior in person, what is it? Good, great, VFib. Okay, so just to give you kind of a timeline of her code. So in general context, she had peripheral IV access obtained before she was pulseless, and it was good access. So there was no plan for any central access during this because she had access. She was bagged with a BVM throughout the code. So the first section, about 20 minutes after arrival in the ED, she was transferred to the resuscitation room. She received her first dose of epinephrine. At the first pulse check, she was in VFib, so she was shocked. She had received a second dose of epinephrine, and then at a second pulse check was still in VFib. At that point, she was given calcium bicarbonate, and she was subsequently shocked twice with one additional epinephrine. There wasn't any particular reason for these medications, like a history of hyperkalemia or acidosis that they were aware of. They were just trying to treat any causes of her arrest. What? Did I hear someone say something? Not at this point. I have more slides, but yes. So Dr. Silverberg brought up magnesium, which is also a great point in a patient in VFib. But the patient achieved ROSC before the magnesium could be administered. At this point, they discussed intubation, but the patient was having spontaneous respirations. So they decided to hold off for a minute and kind of proceed with additional diagnostics. So her physical exam at this point, oh, yeah, right.
I'm sorry. At that point, when she has the spontaneous, is there a medical status?
So she was obtunded. At this point, she was obtunded. She didn't return to a normal mental status, but she was at that point for them protecting her airway. And lungs were clear. And really her physical exam was pretty unremarkable besides her obtunded mental status. Unfortunately, she lost pulses again, and this time was noted to be in VTAC. So at this point, she's had VFib and now she's in VTAC. So they gave her a bolus of lidocaine and started her on a lidocaine drip. She had 2 subsequent shocks. At this point, she did get the magnesium. She was also started on an epi drip. And they obtained ROSC, as you can see, 2 minutes later. They probably hadn't even finished giving all these medications by the time they got ROSC. But then she had multiple episodes of VTAC with a pulse requiring shock. At that point, they decided to stop her epinephrine drip and intubate her because of her refractory prolonged arrest. So she received succinylcholine and then a push of fentanyl and a push of midazolam, and then was placed on drips. The vent settings, just kind of give you a context, she was profoundly hypoxic, requiring an FiO2 of 100% and a PEEP of 7.5. There's no documentation of the tidal volume and the respiratory rate, but we can kind of assume based on her prolonged shock that she might have had some acidosis. So you would think about increasing her tidal volume, especially when you get her labs back if you look at her acid-base status. So at this point, she has ROSC, she's intubated, so now I have to think about what caused her arrest. So does anyone want to give me some things in their differential for this patient? Long QT, short QT? Okay, so long QT is going to be torsades. I've got ischemia, MI, anything else? So if you have a short QT, MI, you don't want to give me anything else? Okay. Paul's mentioning substance abuse, and we are clarifying specifically cocaine, and we're clarifying Shane is referring to long QT, so like a genetic prolonged QT. Anyone? Oh, eclampsia? Oh, I like that. Brugada, hey, 55. They've been older. So Brugada, which is another underlying predisposing factor. Anyone else want to add anything? Electrolyte abnormalities. Not to brought up tox, absolutely. TCAs. So despite the fact that we use H's and T's for PEA and asystole, I actually want to use this as a structure for a differential. You guys started to mention a lot of them: electrolyte abnormalities, MI, toxin. We talked about, I mentioned before that she was hypoxemic. Even though we use this as a structure for PEA and asystole, it's actually still recommended in the ACLS protocols to consider reversible causes in a patient with VTAC or VFib. So based on this patient's initial physical exam, as short as it was, the triage, vitals, and finger stick, we can knock a bunch of these diagnoses off the list. So this is kind of what we were left with. The ischemia that was mentioned, toxins that were mentioned, a couple more electrolyte abnormalities that we can't rule out because we don't have any further data. So at this point, what tests are going to help us rule in or out these diagnoses? It's kind of our next steps. Oh yeah, Dr. Bacon.
Here on this listing, acidosis, if she's acidotic, a suspicion is that it would be as a result of the arrest, as opposed to the cause for the arrest.
Yeah.
Because initially it seemed like clinically there's some time to get some blood work, and she didn't look like she was smiling or anything of that nature. So there's something else to consider.
Absolutely.
That's kind of lower than the other side.
Dr. Bader was just pointing out that in this particular patient, the acidosis, if she were to have acidosis, it would most likely be a a result of her arrest and not the cause of her arrest. She didn't appear to be in any acidotic state when she arrived. Okay, calcium channel or calcium channel blocker toxicity. That's a consideration under toxicity. However, moving away from the things on this list, how are you gonna eliminate or prove these? What tests do you want? Great, so labs, EKG, bedside sono, labs, ultrasound, great. Those things, a shock, even, you don't even have to say labs, can help you deal with a lot of these. So we're gonna go first to the EKG. Would someone like to interpret this? Either globally or specifically. Yeah, Calvin, you wrote inferior, is he not listening? I like that, he typed and I was looking over there. Calvin, you wrote inferior MI. Do you want to give us more information about that, what you're seeing? You can type it if you want.
I can speak as well. There's like ST elevations, 2, 3 AVF, and then reciprocal depressions in AVL and 1. I'm looking at my TV, I'm not looking away.
Okay. Yeah, and there's also concern for, wait, hold on. Oh, there's my mouse. Posterior extension because of the ST depressions here, as well as a possible RV infarct, which obviously they didn't spend too much time getting alternate EKGs, but we're concerned about ischemia. That's we've kind of gotten there. But we talked about further testing, what else we would want at this point. And so you guys mentioned point of care ultrasound and VBG. So just to give you all the data you asked for, this is her VBG.
All of this testing is done after the arrest.
Yeah. So these labs. Yeah. So the EKG was done at this point in the code, because unfortunately for this patient, the code is not over yet. So at this point in the code is when we have this data. It's when the EKG is done and when the blood gas is done. The ultrasound is being used for another procedure. So you can't have an ultrasound right now. You'll get it later. It's in central sterile because somebody used it with, you know, like put blood on it. So it's got to be cleaned. There's no ultrasound for you right now. That's what I'm telling you. So now moving right along. Can anyone add or update our problem list? I know we've all put inferior MI on there, but what else? Hypokalemia. Thank you, Paul. Lactic acidosis, respiratory acidosis. Yeah, so a mixed acidemia. Anything else? There's like, okay, thank you, Robbie. So ventricular storm or VTAC storm and cardiopulmonary arrest, right? This patient arrested. So her list has gotten much more complicated since we first started. And obviously a lot of these things are related to each other, and I'm not getting into like causative, but she had an arrest with electrical storm due to an occlusion MI. So the next thing the team did is they called a code H to get cardiology at the bedside. So cardiology arrived, they reviewed the EKG, and they agreed this patient needed to go to the cath lab. Unfortunately, she went into VFib arrest again. At this point, she was loaded with amiodarone and placed on amiodarone drip and shocked 3 times with ROSC. The rest of the code, she continued to have a pulse with a good waveform on pulse ox, but did require 6 additional shocks, an additional pulse of lidocaine and a norepinephrine drip. At this point, she was transferred to the cath lab. The heparin drip was not started before she went to the cath lab because they didn't want to wait for it. And at this point, I'm going to go back because I can't remember. It's not there. Her door to balloon time is like over 200 minutes, both by triage and by the EKG. So they didn't want to delay the patient any longer, but she had long passed our metrics that we use for a goal of a good outcome. And for completion's sake, cardiology did a POCUS while they were down, and it showed inferior wall hypokinesis. So at this point, like I mentioned, this patient had electrical storm due to an occlusion MI. So I'm going to talk about 2 clinical questions related to this patient. The first one is the role of beta blockers in a patient with electrical storm. And then the second one is, should fibrinolytics be given to a patient with electrical storm or refractory VTAC due to myocardial infarction or ischemia? Before I talk about, does anyone have questions about the details of the case? Dr. G?
I just have some comments.
Sure.
One is that I have seen a couple times, including in my mother when she had her arrest many moons ago, that defib and VTAC can present as seizure, or what looks like a seizure. It's one of the, maybe a weak part of the brain is not being perfused, and that gives the seizure activity initially. In addition, I don't know if everybody remembers a year ago, but Metaanalysis gave a very nice talk on syncope versus seizure, and talked about how you can be fooled with one or another. And then for me, I think you always have to treat the underlying cause. And you find that MI and she has RAS, she has to go to, I think she has to go to the cath lab. The other interesting thing about EKG, can I just
go back to the EKG? Yeah, absolutely.
Yeah, there was an old study, everything I know is old, but there was an old study that showed a couple things. One is that if you have elevation in an inferior wall, if the elevation in 3 is greater than in 2, that does point to right ventricular infarct. All inferior wall might have right side lead, but especially that's a big clue. In addition, there was a study that showed that if with a right ventricular with an inferior wall MI, you have ST depressions in the precordial leads, those are not considered reciprocal. That's, like you said, could be posterior extension, or that could be subendocardial ischemia on top of the MI. And they have a much worse prognosis than just the plain inferior MI. So it's a very dangerous looking EKG.
So just to summarize, if you guys can't hear what Dr. G was just saying, at the end he was discussing the EKG findings that I mentioned before. So if the ST elevation in 3 is greater than 2, that's concerning for right ventricular involvement. And then the precordial ST depressions are concerning for posterior extension. And then before that mentioned Natan, who's one of our graduates, lectures on syncope versus seizure. And prior to that mentioned that from personal experience, seizure can look, VTAC can look very much like seizure. I think I summarized as best I could. Dr. Willis?
Are you going to go into anticoagulation for MI at all?
Not really.
Okay, I just didn't want to steal what you were going to say.
No.
A quick point about the heparin, I think that was the right thing to do. It has no mortality benefit. So you should not have waited for that patient to start a heparin drip. The right thing to do is to go directly to PCI because that's mortality.
Yeah. So Dr. Willis is mentioning there's no mortality benefit to the heparin drip, so don't delay a patient's definitive therapy for that heparin drip. Dr.
You shouldn't delay for anything. I think even if you can't get this person out of BT, you put them on the thumper and they get continuous CPR, they should go to cath lab on the thumper if you can get them off there.
I'm not
going to give you pushback with that, but the only thing that's going to fix this person is a cath.
I'm not going to quote Dr. Silverberg because I quoted him later in my lecture, so you'll see it later. Hassel?
Sorry, what was the door to EKG?
She was triaged at 22:54 and her EKG was 0016, so an hour and 20 minutes. So it was an hour and 20 minutes from triage to EKG, and both obviously an hour 20 minutes longer. So if you do EKG to balloon time, she still was over 200 minutes or 100. She was definitely over 120.
I'll bring that up again later.
When I get there. Okay. Yeah.
So like for the husband after the arrest, that like there were no symptoms involved that like you saw her.
She just did.
Like, activity.
Yeah, and that's it. She wasn't like complaining of anything before or after. Okay, so let me jump back to where I was. Yeah, I had the exact door to balloon time somewhere and I don't remember where I put them. Okay. Yeah, so the things I'm going to talk about first, I'm just going to talk about the definitions of electrical storm and refractory VTAC, then the treatment of electrical storm, and finally fibrinolysis for an occlusion MI. So first, just looking into electrical storm, there's a lot of different vocabulary that are used to describe a patient like this one. So from most of my reading, electrical storm is considered to be multiple recurrence of ventricular arrhythmias over a short period of time. So you can get them out of their arrhythmia, but they quickly return. Refractory VTAC is persistent despite treatment. So it doesn't matter how much you shock them, how much medication you give, they never return to a non-VTAC rhythm. And then sort of an umbrella term for both of them that I'm going to use is shock-resistant VTAC, because both of these patients are considered to be shock-resistant, but their underlying pathology can be a little different. And the consensus definition among some of the organizations is three distinct, for electrical storm, is 3 distinct episodes within 24 hours. And then if it's a patient with an ICD, 3 appropriate shocks within 24 hours. Obviously, this patient had many more than 3 and many less than 24 hours, but that's just the official definition. And then the pathophysiology underlying electrical storm is an increased empathetic surge of endogenous catecholamines, increased intracellular calcium, and then usually occurs in patients with structural heart disease. So you have an underlying kind of like milieu that's predisposing you, and then there's some kind of trigger that pushes that patient over the edge. The triggers that are most common, so kind of separating acute myocardial ischemia from other patients. So a patient with acute myocardial ischemia may have no underlying milieu. It's the acute myocardial ischemia. If they don't have acute myocardial ischemia, say that 10 times fast, they have something else underlying. So a structural heart disease, Brugada was mentioned earlier, and then something else pushes those patients over the edge. So that can be a sympathomimetic, a proarrhythmogenic drug, electrolyte disturbances, acute heart failure, thyrotoxicosis, or QT prolongation, be that something underlying like Shane had mentioned, or one of these other things causing an acute acquired QT prolongation. So it's not always just one thing. If it's not an acute MI, it may be more a trigger on top of an underlying substrate. And I'm going to go into the treatment. So just starting with the treatment of VTAC and VFib. This is a really nice, beautiful flow chart that Drs. Conrad and D'Souza made for my section of the RISE manual last year. I'm just going to focus in on the section for VTAC and VFib, just to mention that it does mention treating reversible causes like we talked about. And it mentions that currently the recommended antiarrhythmics are amiodarone and lidocaine. Specifically for electrical storm, there's a couple other things that you should think about. I mentioned that it's a sympathetic surge, so reducing that surge in any way possible, pain control, sedation, intubation with sedation with propofol and benzos if needed. Pressors, obviously, if they're needed. This patient did get epi and norepi. There's a hypothetical kind of like physiologic benefit of avoiding things that stimulate your sympathetic receptors, because that could worsen the sympathetic storm, but that's not something that's been studied. And then antiarrhythmics, which I'm going to get in on the next slide. And then 2 kind of down the line treatments that I think are worth mentioning are the stellate ganglion block and double sequential or dual sequential defibrillation. I'm not going to go into the logistics of that, the evidence behind either of them, but just be aware that there are options kind of as you progress through your treatment. So these are the antiarrhythmics that are worth discussing in a patient like this one. Amiodarone and lidocaine are the 2 that our patient got. She also got magnesium. She did not get a beta blocker, but just in terms of treating someone with prolonged QT, torsades, or electrical storm with magnesium, it's not just 2 grams, it's 2 grams and then 2 more grams and then a drip. You're not going to just give them 2 grams and then stop. So this is just a nice chart from one of my references that goes over all the doses, which I think is helpful. We don't use these medications. I think we use amiodarone pretty commonly, but at least I haven't used propranolol IV a lot in the ED and haven't done too many Esmolol trips. Going through each of them, so amiodarone is class 3 antiarrhythmic. And in this case, its benefits are inhibiting adrenergic stimulation and increasing the refractory period. It is still considered first line in electrical storm, especially when compared to lidocaine. But there are increasing studies about beta blockers being beneficial as well. Magnesium I kind of touched on already. The beta blockers are class 2 antiarrhythmics. So the 3 up here are Esmolol, propranolol, and metoprolol. In this patient, propranolol or Esmolol is recommended. I think Esmolol is nice. It's quick on, quick off. But propranolol can be given as a bolus, so it might be easier to obtain. And then the last one, lidocaine, which is at the bottom, kind of, I don't know why it's randomly indented down here, is a class 1B antiarrhythmic, and it's supposed to suppress automaticity. But it's either equivalent to amiodarone or less effective. And just speaking a little bit more about Esmolol. So I think it's a great adjunct from all the literature that I reviewed. It's definitely not something that should replace your first line antiarrhythmic like amiodarone or lidocaine. But I really like this graphic because it kind of talks about why it's a good choice. Where's my, okay, there we go. So it's a sympatholytic. It has a short half-life. It has a fast onset. And you're taking a patient who is in refractory VFib with increased sympathetic tone and giving them epinephrine, which is going to increase their sympathetic tone. So this is kind of a graphic that talks about the threshold of a patient going into VFib. And so all of these things that are happening are lowering the threshold, but Esmolol is raising that threshold and making it harder for that patient to go back into VFib. These are two studies that are really commonly cited. They're not exactly well designed. They're not exactly practice changing, but maybe there will be data to be practice changing in the future. So I like this paragraph that's in the bottom that says if you get a patient coming with refractory VF, or I think in this case, if you have a patient in refractory VF, drop amio and Esmolol, and then they recommend doing dual defibrillation, which is here. Like I said, I'm not going to go into the details of these because it was a lot of research just to talk about the things I'm talking about. But there's a lot of data. There's YouTube videos about how to perform both of these, but they're considered as kind of third and fourth line treatments. And lastly, about electrical storm, I really like this pathway from the Internet Book of Critical Care. It not only contains all of the doses, but it also gives you a nice pathway of what to do next, while on the left reminding you that you still need to be reducing their sympathetic surge, giving them analgesia sedation, getting access if needed, giving them a vasopressor if needed. And then eventually, like was alluded to by some of our attendings, they need to end up in the cath lab over on the right once they are ready to get there. And then one last, because I can't leave out IM related things. Oh, Paul, if giving Esmolol drip, do you stop giving epinephrine pushes Q 3 to 5 minutes? I don't know. It's a great question. Does any of our attendings have any experience with that? Paul wants to know, should we stop giving epinephrine if we put someone on that smaller drip? I don't know.
I mean, if you're reading the bottom of this this little form, it says each individual episode of VTAC is treated per ACLS algorithm. So I'm assuming that you should still give the epi.
I think so.
I will just say though, we know that epi doesn't really help.
Yeah.
And especially in patients who are saying are in electrical storm, probably not going to help. So I don't think you'd be wrong in not giving it. And it's probably just going to be adding a lot of extra stuff in this patient's body that's probably not going to have a big benefit. So I've never given Esmolol drip or something like this, so I can't really answer it. But I think in my mind, I wouldn't be that worried about the epi in this particular patient.
Okay. So what Dr. Hassel was saying is, we know that the evidence for epi is not that great in the first place. And then in particular in this patient who already has increased sympathetic tone, that it might make sense to not worry as much about the epi and give the Esmolol. To quote Subham, more epi is bad. So I think that you could probably not worry too much about your epi, or maybe space it to 5 minutes because we all like to do it like right at 3 minutes, but focus more on reducing their sympathetic surge with other medications.
I guess you'd be blocking the beta action to the epi anyway, right?
Yeah.
Giving the beta blocker.
Yeah.
So all you would be doing is working on the alpha receptor. So I guess if you can think this much about the code when you're in it, if you think that the patient needs pressor support or alpha, like acrovolemic or in shock, maybe there is some benefit because you are blocking the bad effects of the epi that you don't want to have on them. So maybe the person who researches the thought about it said to continue to see what sort of.
I like that. So Dr. Wills was saying the beta blocker is going to block the beta effects of your epi anyway. So your epi is going to become kind of a pure alpha pressor anyway. So if you have a patient who needs pressors, then maybe you're blocking those negative effects of epinephrine. Yeah, which is actually why in the bottom left, they recommend phenylephrine or norepinephrine because hypothetically there's less beta activity. Yes, beta.
Well, I was going to say, I can imagine that code conversation. No, but I'll add one more thing. Is if you are indeed blocking the beta and you're giving an alpha, let's say basically you're giving them phenylephrine, right? And a theoretical side effect of phenylephrine is bradycardia. So that's, just to add another layer of the theoretical.
Yeah, I like that.
Who knows if that's actually true, but.
Yeah. So Dr. Beta mentioned that with phenylephrine, you're giving them effectively phenylephrine. One of the side effects of phenylephrine is bradycardia. which wouldn't be so bad in this situation. Yeah, Dr. G.
Another thing I just wanted to point out that you have there, and then I have a question for you, but I just want to emphasize that it says on top, non-torsade storm.
Oh, yeah.
If you, for example, saw that the person was having short runs first, and you were able to see there was a prolonged QT, you don't want to use amiodarone or procaine.
Absolutely.
Right?
Yeah.
Because they prolong it, it will make it worse. If it's polymorphic, but it isn't prolonged QT, yes, and then you can try those. So
Absolutely.
that's clear. My question to you is, what about the use of high-dose steroids? That has been, some people have advocated it.
In this patient?
In patients with refractory VFib and VTAC and then arrest. Did you come across anything with that?
I did not. First, I'm going to summarize what you said in the beginning, which was to point out at the top of my slide, it says non-torsade VT storm, because patients with prolonged QT should not get QT prolonging medications. So this is knowing that your patient does not have a prolonged QT. And then secondly, Dr. G was asking me about high-dose steroids in VT storm. I didn't look specifically for that, and it didn't come up in any of my general research. So I don't have a good answer.
Some people have brought it up in the past, but again, it was more, based on anecdotal stuff rather than any proof.
And I didn't, a lot of this is based on anecdotal and case reports as well. They're just coming out with some better studies about Esmolol in the past couple of years. And this is my last little, because I can't leave IM out of it. This is what happens to your patient after you resuscitate them and get them out of their VT storm. So the left side, we all know if they have ACS, they go get treated in the cath lab, and then they have their EF reevaluated afterwards. And then on the right, it's just important to think about the underlying substrates. So if they don't have an acute MI, they likely have structural heart disease or an inherited arrhythmia. Some patients have no structural heart disease, but those patients have a kind of longer workup to find out what caused their VT storm. So I just think it's useful to know where your patients end up. And it's kind of interesting to follow our patient as she moves down this pathway. Okay, so I'm gonna jump to intra-arrest fibrinolysis. Sorry, my throat's getting sore. So at this point, I wanna bring you to the point in her care when we have our EKG. So before that, we were treating VT storm, electrical storm. We didn't know the cause. Now we have the EKG. So we know that this is due to ischemia. And what should we do now? How should that change our management? Which some of our attendings already alluded to. And I will get to more of their responses in a little bit. But first, I want to talk about some of the data that I found. So first, I'm just going to address a very large and commonly cited trial called TROIKA. It's thrombolysis during resuscitation for out-of-hospital cardiac arrest. Obviously, our patient arrested in the hospital, which is kind of unique. So a lot of the data I'm going to talk about is extrapolated from out-of-hospital cardiac arrest. This is commonly cited as a reason we should not give TPA. It included all rhythms, as you can see up here. And even when they looked at subgroups with VFib, pulseless VTAC, they didn't show any benefit. But it was also based on presumed cause of cardiac death. So they didn't say this person is diagnosed with an MI. And some other just kind of strange designs of this trial, which make it less applicable to our patients, is that the study drug was administered within 18 minutes of arrest, and ROSC was usually achieved 8 to 10 minutes later. So this is not a patient with a prolonged arrest. This is not a patient where we have a lot of data beforehand. So it just really doesn't apply to our patient or many of the patients that I'm going to talk about from now on. So to outline kind of the characteristics of patients I'm going to present data on from here on out. It's patients in electrical storm, VT and VF with a diagnosed STEMI. In our patient, she's in hospital cardiac arrest, but I have to extrapolate some data from out of hospital, and then refractory to ACLS. So it's a much narrower patient population to look for data to support or to determine if we should support fibrinolysis in this patient. The answer is there's not a lot of data in a patient like this because it's pretty rare. But the things that I could find, first, a meta-analysis that included 4 studies that look specifically at patients who received TPA having a known MI. 3 of them looked at outcomes, positive outcomes, and 1 just looked at bleeding risk. So I kind of boiled down all 6 of their results charts into one chart, which just showed that in the studies that looked, patients who had an MI and received TPA had an increased odds ratio of all the survival types and long-term neurologic function. This is a really small meta-analysis, only had 7 papers, and one of the papers for acute MI just looked at bleeding. But they did note that there was no statistical increase in bleeding, statistically significant increase in bleeding, which is always a concern if we give TPA during arrest. Is our patient going to exsanguinate because we are constantly compressing and causing microbleeds? And the answer, at least in these studies, was no. Another study, which I think is really unique and doesn't exist in the United States, but the system is very cool. They have physicians in the field who direct resuscitation and make the decision to administer TPA in the field. So these are patients that are out of hospital, but it's as close to in hospital as we can get because these physicians are in the field making this decision. And they looked, as you can see, as you go down the left, they looked at patients with STEMIs or concern for infarction. And then they specifically looked at patients who received thrombolysis during or immediately after CPR. And depending on how they broke it down, approximately 33% of patients who received thrombolysis during CPR survived to hospital discharge. 46% of those who received it post-ROSC survived to hospital discharge, which is pretty incredible given the fact that usually it's like 10 to 15%. They don't comment on neurologic function, unfortunately, but it does show that it was beneficial for some of these patients. And then the last couple patients I'm going to present are actually just a case series and a case report, but they're most applicable to our patient. This is a case series that I summarized. It's 3 patients who all came to the ED complaining of chest pain or some other complaint that caused them to get an EKG. They were diagnosed with a STEMI, then they had VT or VF arrest right in front of the providers. TPA was administered if they had unsuccessful ACLS, which was 8 to 21 minutes. So the longest patient waited 21 minutes for their TPA. All 3 of them had ROSC within 10 minutes, and all 3 of them were discharged home within 14 days with no complications from their TPA. It doesn't talk about if these patients were in STORM. They were considered to have shock-resistant VTAC, and they did have a good outcome with TPA. And then the last one that just sounds like our patient, except that they arrested in the field. They had prolonged ACLS. They were diagnosed with a STEMI intraresuscitation. They had TPA administered with ROSC in 4 minutes, and they were discharged with an intact EF at 10 days. So these are some of the studies that I found. Like I said, the evidence is not amazing for it, but I think in a patient like this one, there's some evidence to kind of convince you that maybe you should consider it. So then I decided to ask our attendings. So this is a poll that I wrote and asked them to fill out, sort of contrived and simplified our patient's case and asked them if they would administer thrombolytics or activate the cath lab. And about 2/3 would activate the cath lab and 1/3 would administer thrombolytics. I didn't give them the option to choose both. So some of them included in the comments that they would like to do both. So for that reason, I included some comments. You can see Dr. Silverberg's opinion on line 5. 1, 2, 3, 4, 5. Yeah, which he already quoted, so I don't have to read out to you. But there was a lot of discussion about can I do both? And I like the last 2 because one says put them on a thumper and get them there, and the other says don't send them there until they're stable. So it kind of spreads the opinions on what they would do. I don't know if anyone who's here in the audience today wants to, besides Silverberg, because I outed him, wants to fess up to what they wrote or add any other comments before I keep going.
I would not waste the process.
Okay.
This patient, their chance of survival is revascularization. So yeah, you can push TPA. I think if I was at Kings County, I'd push TPA. If I was at downstate, I would put that patient into the elevator in cardiac arrest any day of the week. This time is myocardium is brain. The longer you wait to revascularize, the less likely that patient has a chance to live. ROSC or no ROSC, get into the cath lab. That's their best chance of survival. Hands down. There's no question in my head that if the patient's in cardiac arrest and you take us from STEMI, no matter what is on, no matter how unstable the patient is, you get that patient in the cath lab.
We've tried this before in cardiology blocks, but that's the right thing to do.
While they're in CPR. Okay, so they were saying that Dr. Schechter was agreeing with Dr. Silverberg to get the patient to the cath lab while active CPR, even if cardiology puts up a fight.
Who's your family member? That's what you want to have in a place that has maybe more advanced cardiovascular techniques. They would get an Impala, they would get a pressure support device. And that's
Dr. Willis was saying other places might get an Impala or some kind of pressure support device in the ED. Yeah, getting placed on ECMO, which I think Robbie mentioned in the chat earlier.
This would be an interesting question to ask cardiologists, is that part, the logistics of it. And if you're doing a cath, however they're going to access femoral or radial or whatever,
yeah.
And then the thumper's actively doing chest compressions while they're trying to guide the wire. Just how successful is that? I wonder if there's data on just that. And while there's active chest compression, the thumper prolonged arrest doing cath PCI. Not only do you have to actually guide the wire while the part is moving with active chest compression, but then deploy a stent. And then, so I'm just wondering how successful it is. I'm sure it's not.
Just from experience.
Beta was just asking about the idea of asking our cardiologist about the logistics of trying to do a cath with active CPR with the thumper. And
Hannah? There's a few cases that I saw in CCU, while on CCU or the cath lab when the patient arrested, they just stopped.
Yeah.
And then you resuscitate, and the resuscitation is very difficult in that room.
Yeah.
So like after seeing like the data that does exist on TK, I don't know, for me logistically that seems like the better options because it's very difficult to resuscitate.
So Hannah was talking from experience on CCU, and our cardiologists do stop what they're doing if the patient arrests and they don't know how to perform ACLS. So it is a little scary. And I can say that I've been doing chest compressions while Dr. Poston cannulated someone for ECMO on the cath lab table. That's also a mess. So I think our practice environment is a little unique in that way. And I'll be interested to see my classmates in our group chat with different cardiology capabilities and different perspectives and kind of how their practice will be different. Can they do ECMO at downstate? No. But they did for like a month.
They have the capability.
Yes, they have the capability, but what is Catholic going to do if they don't have ROSC? I mean, ideally they would get perfusion and then you would have ROSC.
So I was going to say, when you have a solid ECMO capability and you put this patient on ECMO, then you don't necessarily have to continue.
Yeah, then it's much easier.
Perfusion.
Yeah.
That offers you a bridge while the patient is getting externally.
Yeah. So Dr. Bader is saying if you can put the patient on an ECMO circuit, then you don't need active CPR, and it's going to be a lot easier to reperfuse them.
And I mean, we should always try to practice not just the way downstate functions, but also the way places function everywhere. So I mean, you might go to a place that has a very functional cardiology service and really save lives, like getting to the cath lab as soon as possible. I mean, I think I probably have an availability by one of my friends, his dad, had chest pain and went to the hospital and he arrested within minutes of getting to the hospital. And they took him to the cath lab in arrest. Like they were just resuscitating him in the elevator. And his door to balloon time was like very low. He was a cardiologist who called his friend around the cath lab to tell him that he's on his way to the hospital with a possible MI. So they were already waiting for him. And so he had no myocardial damage after that. He arrested, went to the cath lab, got revascularized, and was totally fine after that. And so that's kind of, I think, the ideal. He was a very different hospital in Boston, and this obviously is different, but I think we should always strive for the ideal care for all of our patients. And so I think that's the ideal. And you're going to get pushback from cardiologists, and I think you can fight a little bit, but so you should always. I think revascularization is the best chance for our patients, and that's what we should always push for. The thing that's going to give our patients the best chance. If you can't get into the cath lab, then you're going to get the TPA. So you got to get them revascularized some way. But I think cath is going to be a much better option than systemic thrombolysis.
And just to summarize, Dr. Schechter was talking about a case of a friend who called the cath lab to tell them he had an MI and then arrested at the hospital. So had a really short door to balloon time, and we should strive to care for all their patients that way. Is that good? I like doing these summaries.
Do you have any more slides?
I do. Yeah. So quickly, we're going to talk about the ending of this case. So she did end up going to cath lab, as we mentioned. Oh, here's my door to balloon time. 245 minutes from triage and 163 minutes from EKG. I'm putting here somewhere. So she had diffused 100% stenosis of the RCA with thrombus and a stent with 0% residual stenosis. In cath, her EF was 35%. She was transferred to the CCU on an intra-aortic balloon pump, amiodarone drip, lidocaine drip, norepi drip. and her official EF was 15% later that morning. There was a concern that she might need a heart transplant or ECMO, so she was transferred to NYU. At NYU, she did have VTAC again on day 3, but her pressors were DC'd on day 4. She had an echo with a normal EF on day 5. She was extubated day 7, ambulatory day 11, and I think she got discharged on like day 14. So incredibly, she had a really great outcome, and actually has had multiple outpatient appointments. She's off amnio. She's about to have her life vest removed. She's on goal-directed medical therapy. So one thing that we were talking about when we were going over this case with the CCM team was trying to prevent, like Dr. Schechter mentioned, trying to prevent any myocardial damage. And this patient is extremely fortunate that she probably has myocardial damage, but she has a return to normal EF, which is incredible. And so our goal would be to have that happen for all our patients. And yes, Paul, we have intra-aortic balloon pumps in downstate, but I don't think they place them in the ER. Thank you. I don't know. Angela was supposed to be here, but yeah, so it was at 11 p.m. at the beginning of a night shift. Yeah, in the hallway at downstate. So yeah, I may have embellished a little. So that's my summary. Sorry, we don't have much time for questions, but there's lots of good discussion. Yeah, and those are all my really tiny font references.
Great there.